To start the next session, I cordially invite Dr. Mustafa Taha and Dr. K. Umashankar. So the next topic is going to be PCNL through the upper pole, why and how.
Good afternoon. Let me invite the next speaker. He's going to talk about, that's a plenary number 7, PCNL through the upper pole, why and how. It's going to be delivered by Professor Rajeev Kumar. He is the current president of SIU. Over to you, sir.
Thank you, and I promise I shall not appear on the stage again after this. So I'll be talking now about something moving away completely from oncology onto stone disease, and this is of course something which is far more commonly done by everybody. We're talking specifically about PCNL through the upper pole, the why and how. And once again, on behalf of the SIU, thank you very much for the invitation to be here as a part of this meeting. I have no disclosures to make. So when you look at a PCNL, this is standard teaching, textbook teaching, that your track should be short and straight through the fornix or the papilla of a calyx. You should preferably be accessing the PCS through a calyx that has a wide infundibulum. And despite there being a large number of techniques now of doing PCNLs, which means you could do it prone, supine, partially one way or the other, ultrasound guided or fluoro guided, the fact is that the commonest technique that's followed worldwide is a prone fluoro guided PCNL. The second important thing to remember is how do you puncture the PCS? A discussion that I've had with many urologists around the world is that I can puncture blindfolded, or I can puncture, I know how to puncture, I will get in, but I can't teach you how I do it. That is the commonest way in which a puncture is made. It's through experience and intuition. Fortunately, there is a well-defined technique which is to be followed if you are supposed to teach people how to do a PCNL. And those are two techniques typically, triangulation and the bullseye technique. Between these two techniques, the bullseye technique is the one that is easier to learn and easier to teach. Now, when you access the PCS for a PCNL, the commonest track that is made by most people is through the middle calyx. The description of the bullseye technique that was given by Miller almost 20 years ago was again following the anatomy of the middle calyx. When you look at the upper polar calyx, actually it is sometimes the best access to the kidney because it gives you the widest view to the PCS with the least amount of torque and manipulation. It also has the lowest amount of colon injury risk, but it does have some additional complications, particularly about the hydrothorax. This is actually some examples of patients who've been operated through the upper pole access. There's a patient with bilateral complete staghorn stones. Access sequentially first on one side, then on the other side through the upper calycial access. And when we looked at about 83 patients who had an upper calyx access, this is almost a 10-year-old data now, we found about a 10% risk of developing a hydrothorax. But not all of them require intervention. Although they do develop fluid, more than half of them do not actually require an intervention and the fluid goes away on its own. Now let's look at the bullseye technique. The bullseye technique, like I said, was classically described for the middle calyx. It's based on the anatomy of the middle calyx that when you rotate the C-arm towards you, that is about 30 degrees towards the operator, in the majority of the kidneys, the middle calyx, posterior middle calyx, is in line with this 30-degree angle, and therefore if you make a puncture in line with this angle, you will enter the calyx in the middle posterior calyx, and that's called the bullseye technique. Unfortunately, when you look at the upper pole calyces are not oriented mediolaterally the way it is described for the, not oriented anteroposteriorly the way it is described for the middle calyx. In the middle calyx, or in the lower calyx and in the upper calyx, the orientation of the calyces is mediolateral, not anteroposterior. And therefore, the classic bullseye technique does not work. If you were to use the classic bullseye technique, you'll enter the calyx from the side and not from the top. Therefore, the most accurate angle, if you were to access the calyx in the line of its infundibulum, would be to come from the head side of the patient or in a craniocaudal direction. So this is a little bit of an experiment that we did on about 20 patients. First, we measured the angle that the upper calyx makes with the skin, and unfortunately, we found that the angle was about 60 degrees, and you really can't make a puncture in 60 degrees because you can't turn the C-arm to 60 degrees, and of course, you'll end up going above the 6th rib, so you can't do that. Therefore, we do the craniocaudal puncture in something more akin to a 15 to 20 degree angle. We first take a fluoro view in a 0 degree to identify where the upper calyx is located. We then turn the C-arm in a craniocaudal direction to the maximum degree possible, which is typically only 15 to 20 degrees, and you then make a bullseye. And this is what a bullseye is supposed to look like, where the hub of the needle, the tip of the needle, and the calyx are all in one straight line, and therefore you can't see the needle at all. This is a bullseye, and the puncture is then made in this bullseye, and subsequently you turn the C-arm back to a 0 degree to check the depth of the needle. Once the needle has reached the right place, you feed in a guide wire and it goes in. Excuse me. So this is a sequential picture, and this is actually a stone in the lower calyx. You first take a position in the 0 degree, then make a bullseye in a 15 degree angle, then again bring it down to 0 degree once you're reaching the calyx, and then the wire should ideally walk down. So some of the tips when you're doing a superior calyx puncture. First, of course, is count the number of ribs. It's very often that the 12th rib is very short or is missing. When you make these punctures, you want to make sure that you're making it only above the 12th rib at most, and you're not going above the 11th rib. The minute you go above the 11th rib, your complication rate also almost becomes 5 times. And if the rib is missing or you haven't counted the ribs correctly, you can make a mistake and go above the 11th rib. So count the ribs correctly. Try and make your puncture as lateral as possible. The more lateral you go, the less likely you are to puncture the pleura. So this is the 12th rib. Okay, it's not projecting now. Let's see, this might work. Right. Thank you so much. Too much talking in the last 2 hours. So if you go laterally, you see this is the 12th rib. If you were to make a puncture anywhere along here, you're supra 12th, and you'd think your risk of pleural injury is the same. But the fact is that if you make the puncture here in the mid-posterior axillary line, mid-posterior line, scapular line, you'll go above the rib, go above the pleura. But if you go lateral, you won't go above through the pleura, although both of them are supracostal. So go as lateral as possible. Don't do it in the inspiratory cycle, because if you're doing it in the inspiratory cycle, the pleura comes down, and decrease the angle as you need it. Here's another example of where the pleura is located on a CT. If you make a puncture here medially, this is the pleura, and you're going above the pleura, through the pleura. Same cut, if you go laterally, you will not be hitting the pleura, and therefore you will not get a hydrothorax. So our preferred technique is to make a single puncture, dilate it, achieve as much clearance as is possible even in a staghorn. Sometimes we will stage the procedure, which means we'll stop after day 1 with a single puncture, come back after 48 hours, and you'll suddenly find you can clear a lot more stones without making additional punctures and without making pre-placed wires. On the second look, assuming we need a second look, we will then come back and make additional punctures if we need to make them. In terms of our exit strategy, we will always check for clearance endoscopically. Sometimes the large scope is difficult to manipulate, so if you've put in using a 24 French scope through a 20H French sheath, we will then change down to a 12 French scope, because that allows you greater mobility and you can see more calyces through it. If we've got clearance endoscopically, we will also check for clearance under fluoroscopy, and then do a second look if required to the original track. We will always obtain a chest X-ray after checking for air entry if you've gone through a supracostal puncture. Even if you think you've gone lateral, you can hit the pleura. So this is an example of how you can get a hydrothorax, and this is the same patient that I showed you a little earlier. And remember, even though the right side is theoretically lower, the right kidney is theoretically lower. So you would think that your hydrothorax chances are lower on the right side, but we tend to see the hydrothorax far more commonly on the right side, even though the puncture on the right side is lower than the puncture on the left side. So finally, just to conclude, when we use a PCNL, we prefer the upper pole these days. I think most of our punctures, more than 80% of our accesses today are through the upper pole. We do it because it's easy to use and it's easy to teach when we use a bullseye technique to teach people how to do a puncture. We do have about a 10% incidence of hydrothorax when we have gone supracostally, but less than half of them, probably only about 20% of them will require an intervention. Therefore, most of them are asymptomatic, and we will almost always do a chest X-ray. In fact, always, not almost always do a chest X-ray on the next day before we send the patient home. Thank you once again for the invitation, and if those of you who haven't made your plans for next year, the the SIU meeting will be in the UK next year, in Edinburgh, at the last week of October, and we hope to see some of you there next year. Thank you very much.